Well, hello and welcome. And you are not imagining things. We are here on a Friday afternoon. Of course, usually we are here on Thursday. And unfortunately, my schedule last week got a little crazy. And fortunately, our guest was gracious enough to help us to reschedule this for a day that we could both come together and do this. My name is Guy Stevens. I'm the founder and executive director of the Alliance Against Seclusion and Restraint. Many of you that are familiar with our organization know that I started the Alliance really to raise awareness about the issue of restraint and seclusion. And initially, our focus was very much on schools throughout the country. Our focus has continued to grow. It's not just here in the United States. It's across the world, whether it's Canada, Australia, New Zealand, the United Kingdom, anywhere. I had a educator recently contact me from Romania. We certainly have people from all over the world that are part of this community. And our hope is really to spread the word about how we can educate the public and really help to change minds, laws, policies, and practices so that things like restraint and seclusion that can be very harmful are eliminated, not only from schools across the country, but really anywhere that they might be happening. There are far better ways to work with people in really almost any kind of setting. So today, shifting gears a little bit, we do certainly focus a lot on education, but I'm really excited to have our guest with us today, Dr. Maggie Bennington-Davis, joining us for a really special presentation and an interview. Dr. Bennington-Davis will share her experience related to eliminating seclusion and restraint on an acute psychiatric inpatient unit. We're going to have an opportunity, as always, to ask questions during the interview. And of course, this session is being recorded, and you will be able to watch it on YouTube, on Facebook, or download it as an audio podcast. And I'm actually going to share one quick announcement, which I usually don't do before we start, but this one's kind of timely. So I'm going to go ahead and share it with you. Today is the last day to get the early bird pricing for the event that we have coming up in the fall. We are partnering with the Attachment and Trauma Network on a really exciting event. It's called From Compliance to Compassion. It's an event really geared at educators and staff, recognizing that these have been really challenging times these last couple of years, knowing that this year will be challenging as well. We've got a great lineup of speakers coming really to talk to educators about how we can move beyond compliance-based approaches into compassion-based approaches. We've got amazing people joining us. We've got, for instance, here, I'll just kind of show you a couple of sessions. We've got James Moffat doing a session of What's Love Got to Do with It? Everything. We've got Alfie Cohen, who's done a lot of work around rewards and punishment, talking about the negative effects of positive reinforcement, moving from doing to working with. We've got from Canada, our friend Dr. Stuart Shanker and Susan Hopkins talking about self-reg, hopes, hurdles, and hows. We also have here Diane Lewis-Carrell talking about the reset process, kind of a relational process of working with and supporting students. We also have my friend Emma Vanderclift and Norm Kunk talking about the person is not the problem. The problem is the problem, collaborative approaches to behavioral support. And we're going to wrap up the day with Jim Sporletter, who you might know from the film Paper Tigers, who was a principal at a school in Washington State, Walla Walla, and powerful story about kind of trauma-informed approaches. So I wanted to just remind folks that today is the final day for early bird pricing. So that saves you about $50. I'll put the link in the chat here as well. But I just wanted to make that announcement here real quickly. So let me make this go away. I'll put the link in the chat for everybody. And let me get to what's really important here. And Maggie, I hadn't told you about that, and it kind of slipped my mind. So forgive me for that little side road there. But I'm very excited to introduce Dr. Maggie Bennington-Davis. In 2005, Dr. Bennington-Davis co-authored a book, Restraint and Seclusion, the model for eliminating their use in healthcare. Maggie will be joining us for a discussion about how she worked to influence change in an acute psychiatric inpatient facility. And of course, Maggie's a chief medical officer at the Oregon Share Health Share of Oregon, a coordinated care organization serving 400,000 people enrolled in Medicaid. She led the development of a culture change model, and culture change is so important, at a regional medical center for the implementation of trauma-sensitive services, with a subsequent elimination of seclusion and restraint on an acute psychiatric inpatient unit. based on the early work of Dr. Sandra Bloom. Maggie co-authored a book, published articles and chapters on the subjects, has done numerous consultations and presentations nationally and internationally regarding organizational change, trauma-informed, engaging environments and leadership, and of course completed her MD and psychiatric residency at Oregon Health Sciences University, where she remains on the faculty, and a Master of Medical Management degree at Tulane University School of Public Health. And of course, Maggie, I had the great pleasure of meeting you several months ago, kind of through a mutual connection, and was able to have a conversation with you and learn about your work. And I'm absolutely thrilled to have you joining us today. You know, and I look at this work that you've been doing now for some time and think, wow, you know, people have been out there doing amazing work and getting results that have really been meaningful, and just really honored to have you here. So Maggie, thank you so much for joining us today. It's a real pleasure to have you here.
Oh, thank you, Guy. What a nice introduction. But I'll say that during our discussion a few weeks ago, I was the one who learned a lot about the work that you've been doing, and I'm so impressed and encouraged. I'm going to tell my story today. It's not a very fancy presentation, frankly, because I get to just tell stories. And I enjoy doing it. It was definitely a highlight of my career. Um, you know, I got to do my thing in the healthcare setting, but it really applies to almost any setting, including our own personal relationships, certainly in education. And I know, at least in Oregon, that trauma-informed schools is a thing that is starting to evolve and develop. And that's very gratifying to somebody like me who's been thinking about this for decades at this point. So,
yeah, and I've actually had some interesting conversations recently in Oregon with both lawmakers and educators about bringing about change. So, you know, I might reach out to you again to connect you to some of that work that's being done. I just want to, I'm going to I brought your screen up here so you'll be able to share and run through your presentation. I just wanted to invite members of the audience that happen to be with us here live to feel free to go ahead and leave a comment and tell us who you are and where you're from. In fact, I see one of my friends here from Oregon already on here. So there you go. Very timely here, Maggie. But I want to invite people to tell us in the chat who you are, where you're from. And I'm going to hand over to Maggie to take over in the presentation. We did kind of agree that we would take any questions that folks had either during or after the presentation. So if there's something that you're thinking as things go along, Maggie has been kind enough to offer to answer questions as we go, and I'll be keeping the eye out for those questions. We've already got a couple of welcomes here as well that I'll just share with you, you know, Maggie, and we've got some great people joining us from various places. So I am going to go ahead and hand it off to you. I will try to, I will occasionally interrupt with maybe some questions that are coming through, but I'm going to put myself on mute now and let you take over.
Thanks so very much. Yes, please do post your questions. Guy can interrupt me whenever the spirit moves him. Like I said, this is not a fancy academic presentation. It's just me telling my story. So let me start by kind of giving you a sense of the time and place and space and a little bit about me personally in that time and space. So this all started happening for me in the late 1990s. And that's an important kind of era for y'all to be thinking about, because I think it was sort of the beginning of what is now kind of common parlance around trauma-informed this and trauma-informed that. But back in that last half of the 1990s, the word trauma, or the phrase trauma-informed, wasn't really a thing quite yet. So at the time I was doing this work, we didn't have a name for it. And I'll let you know the name that we gave to it at the time in a minute or two. But a little bit about me right then. I was a pretty new leader. I was a psychiatrist. I am a psychiatrist by training, but I had entered into a position as medical director at a med-surg hospital in Salem, Oregon. And we were developing an inpatient psychiatric acute hospitalization unit, serving mostly adults, but also we had a geriatric program and also a day program for youth and kids. And I was, to be honest, I was a little bit full of myself as a new leader. I thought, oh, I've had all this education and training and I'm ready. I can do this. But and so I got busy on the unit, and we were busy admitting people and doing the best we could to alleviate their symptoms and get them back into their homes or back into their community. But frankly, the experience of doing seclusion and restraint was so soul killing to me. That's the best way I can put it. When I look back, I think probably it comes from when I was about 4 or 5 years old. I broke my arm really, really bad. I jumped out of a tree from a height of about 50 feet, and I landed on my arm and kind of destroyed my elbow joint. And I had to undergo a series of surgeries for that. And what I remember about that time was, as I would come out of anesthesia, I'd often be sort of flailing around in my hospital bed, and the doctor and my mom would be there, but they would put me in restraints. They tied me to that hospital bed over and over and over as I was coming out of anesthesia. So as best as I can kind of ferret out in my own self, that experience stayed with me. And so when I saw it happening, I didn't immediately tie it to that experience, but when I saw it happening to people on the psychiatric inpatient unit where I was working, it just did something to me that was soul crushing. So anyway, that was kind of going on. Well, right around that time, I got to go to my first professional meeting, the American Psychiatric Association. These are my peers. This is my thing. These are my people. I'd gone through all this school. It seemed like for centuries I'd been going to school. I was finally graduated, and I got to go to Washington, D.C. from Oregon to attend this meeting. And I don't know if any of you have ever been or know anything about it, but it's about, get this, it's about 50,000 psychiatrists from all over the world, all in one place. Which is sort of mind-boggling in a lot of ways in and of itself. Anyway, I was pretty darned excited. And so I arrived, and I was staying at a hotel across the street from the convention center, and I went to attend my first session, the first morning of this 5-day conference, and I was met with this huge picket line full of people dressed, in cloaks with hoods like death, and then carrying these signs saying, psychiatry almost killed me, or I'm a survivor of psychiatry, and signs along those lines. And you can probably imagine some of the other not so repeatable slogans as well. Well, I was horrified and a little bit terrified, but also just appalled. And I didn't know what to feel or think. Here I was so excited to go to this first conference of my peers. And here I was faced with actually having to cross a picket line with people who were pretty angry and pretty vocal and had some pretty graphic signs. And one of the first things that entered my head was, I bet my friends who decided to go into dermatology don't have to cross picket lines to go to their national conferences. But then the second thought I had was, I am so proud to be a psychiatrist. We're well trained, we're steeped in science. We have a lot of really good and effective treatments. We help people recover their lives. And something must be really, really deeply wrong that the people we want most to assist in that journey feel this way about the services that they've experienced. And I just thought there's some huge disconnect. We've got to figure out what that disconnect is, because how can anybody heal and thrive if they feel that way about the science and people who are maybe best equipped to assist in that journey. So I returned to my my new job as a medical director on this inpatient unit, and that combined with my own horrible reactions to seclusion restraint, I started looking at all of our services through a new set of eyes, through the set of eyes as this is how we disenfranchise people. We lock them in rooms and we put them in leather restraints. We give them medications against their will. We have so many rules and regulations where while they're with us, they have to abide by sort of or else. And that or else part is really sort of dependent on who's on staff at that moment and how decisions get made about when people go into seclusion. All of that sort of came flooding over me. And I realized that, wow, I need to find a new path or I'm not going to survive as a psychiatrist. So fortunately for me, about that time, Dr. Sandra Bloom's first book, Creating Sanctuary, came out. And if you haven't read it, it's really worth a read. It's now obviously an old book, but I still reread it fairly frequently. It's sort of a Bible to me, to be honest. And every time I reread it, I've gleaned more information. Also about that time, the Adverse Childhood Experiences Study was published in 1998. Sandy's book came out in 1997. Adverse Childhood Experiences Study came out in 1998. Now, not very many people were aware of the Adverse Childhood Experiences Study, also known as ACEs, by the way. Not very many people were aware of it. In fact, it didn't really get mainstream until a few years ago. So it was about 20 years before we caught up with that. But that basically provided some of the science behind what Sandy Bloom had been writing about in her book, Creating Sanctuary, which, again, at that time, we didn't have the phrase trauma-informed, but basically that was the first book that really described creating environments where people feel safe enough that they don't have to struggle to get themselves feeling safe again. And then the Adverse Childhood Experiences Study gave us the science for that. Unfortunately, we had engaged Sandy Bloom by then to become sort of a mentor and guru and guide for us at the inpatient unit where I was working. And she knew the authors of the Adverse Childhood Experiences Study. So I was lucky enough to get exposed to that almost as soon as it was published and really used it as foundational neurobiology for how to understand and proceed in the changes we wanted to make. So that's kind of a long introduction to my story, but hopefully it will help kind of position us.
Yeah, and Maggie, I appreciate the introduction to the story because I think it's really important. And I actually was kind of drawing some parallels in my mind. We have a lot of people in professions that are really aimed at helping and supporting people. And as you shared your story, I think about you coming to DC for that event, and here you've been working towards your education, really in the goal of wanting to help and support people, and then suddenly realizing that there's this other side where people are saying, hey, well, we've been harmed by this. And I think about parallels even in education where teachers are going to school to become teachers because they want to help and support kids. Sometimes, and I'm so excited about your presentation because you hit on something I think is so critical, which is about kind of the culture. But sometimes if you come into a culture that is, very punitive and doing certain things, and based on even your own experiences, you might not have that moment that it sounds like you had where you were like, wait, there's something wrong here. So I really appreciate that. I didn't mean to interrupt you, but no. I love the introduction. And I think that, it brings a really important point. I've talked to professionals on a fairly regular basis that have different viewpoints. I mean, sometimes people are doing things that they feel that they have to do because they can't imagine an alternative. And other times people are like, this doesn't feel right to me. And, feel like we should be doing something different. So I really appreciate your introduction and kind of bringing that, because again, people with very good intentions of helping and supporting people sometimes are going into systems where we need to begin to question the practices and the outcomes and realize what's happening. So anyway, I'll be quiet, but I do want to let people know that as the presentation goes forward, if you have questions or comments, you're welcome to put those in the chat as well.
Yeah, thanks, Guy. I think it's not uncommon, at least in the consultations that I've done, to run into people who exactly they sometimes abhor what they're doing or what they feel forced to do, but they haven't been given any other path. And I think I was just super fortunate to have people like Sandy Bloom in my life, and then the Adverse Childhood Experiences study that started to, spoke to me in my language of science. So here's what happened at the hospital. So it was an acute, inpatient, involuntary psychiatric unit. It was meant to be short stay, sort of crisis stabilization, and off you go. There was quite a high baseline use of seclusion restraint in that at that time. This was, again, in the late 1990s, early 2000s. But what we were able to do was we completely eliminated the use of seclusion and restraint, at least for a few years while I was there. We decreased the use of medications by 30%. Now, this was not by intent. And in fact, some people, as we were decreasing the use of seclusion and restraint, were asking me, well, what are you doing? Are you chemically restraining people? Are you giving them stuff to just sort of knock them out? Well, what happened is I was doing our annual budget for the unit. And maybe some of you do budgets the way that I did, which was basically to take last year's budget and plop it into next year's budget and say, here it is, administration. And the pharmacy director called me up, said, Maggie, why are you asking for so much in your next year's budget for pharmacy spend? And I said, well, his name was Dick. I said, well, Dick, it's the same as we got last year. And if anything, we increased the number of beds we have by a couple. So I just thought, I'd repeat what we did last year. And he says, well, yeah, but you've only used about 2/3 of your budget so far this year. And I was shocked. I had no idea. So we went backwards and started looking to understand, well, what's going on? We're using less medicine. But it turns out, and I'll just cut to the chase, and this will be totally intuitive to people, that medications for almost any condition, I'm not talking about like, COVID or something, but for chronic conditions like high blood pressure or COPD, or I don't know, diabetes even, medications for those sorts of kind of systemic conditions, you need less if you're not so stressed. And it turns out the same thing is true for things like schizophrenia and bipolar disorder and depression. You need less medicine routinely if you're in an environment that is not so toxic. So that was sort of an aha. And again, another one of those sort of drawing a line between neurobiology and what we were doing. We also, on the more human side, we had decreased staff turnover in a unit that historically had not been very popular to work on. In the med-surg hospital, not, everybody wanted to work in the newborn unit or something. I don't know. Not that many people were excited to work on psychiatry, but it turns out that as we changed the environment, what it felt like to be there, more and more staff wanted to stay. So we really had a decrease in staff turnover. We also decreased staff injuries. And maybe some of you have read the literature about how kind of dangerous it is to engage in seclusion, restraint, and hands-on of any kind. That's when people get hurt, not just the person, having it done to them, but also those of us doing too. Everybody gets hurt. And so when we started to be able to show our staff that their injuries were going down in this new model, we started to get some pretty good recruits into our effort. We also had a decreased length of stay. So it turns out that when you stop kind of wrestling with people and instead engage them in their treatment, that they need a shorter amount of time to stabilize and start to heal. We had a big increase in engagement and treatment. And I know when you're reading that, you might think, oh yeah, the patient started to increase more in treatment. I'm talking about the staff.
Mm-hmm.
When we got our staff to stop wrestling or allowed them to, and I'm not for a second blaming our staff, and I'm going to get to that in a minute, but when we created different paths for staff to engage with people, staff got way more interested in actually, what are some of the modalities we can use to actually provide treatment for people, and got excited about that for the first time in a long time.
Mm-hmm.
And then, of course, near and dear to our hospital administration's heart was that our financial picture improved, because it's a lot less expensive when you're not being so one-on-one and hands-on with people.
Yeah, Maggie, this is really interesting because we've seen some parallels in educational environments where they have moved away from using restraint and seclusion, and it's always very interesting because you invariably hear, and I'm sure you've heard, this idea that, well, restraint and seclusion are necessary to keep everyone safe. And in fact, you brought up the point I bring up often, which is people are more apt to get injured when you are using restraint and seclusion. So anything you can do to avoid it really maintains safety for not just the individuals, but for the staff as well. And the impact that then has on staff satisfaction and turnover, we've seen the same thing happen in education settings where it becomes a much better environment. But often the opposite is what people are thinking. They think, well, we need, we hear this from educational environments. Well, these kids need to be on medication. We see the push in the other direction, kind of the, compliance and control types of approaches that are not. It's fascinating to me. The thing I haven't heard in other stories, because your setting's a bit different, is the correlation with medication. And that's so interesting because it makes so much sense. I mean, we know how trauma affects the brain. We know that someone that has been traumatized is more apt to be hypervigilant, more apt to be reactive. We know all of these things, but if we're in a place where people are being more frequently physically restrained or secluded, we're feeding the trauma, feeding the hypervigilance, feeding the potential behaviors versus, putting a pause on that and not having those kind of physical interventions and beginning to build trust and building trust, build the confidence, not only of the patient, but probably of the staff. So it's really interesting to me, all of those things that you bring out. I think about Grafton Integrated Health, which was a organization that brought forward something called UCARO, which is a trauma-informed alternative to restraint and seclusion. They ended up saving millions of dollars over a 10-year period. That wasn't their goal. Their goal wasn't about saving money. Their goal was, all these injuries. I mean, they had workman's compensation claims that were through the roof. But to see, again, across settings, similar results to me is really, really interesting.
Yeah, I'm going to add a little bit to what you said. You talked about the building of trust, not only for the person who's experiencing the seclusion restraint and the staff, but also vicariously the other people on the unit.
Right.
It's astonishing how, something that happens to one person on the unit affects everybody in that community. So that's what we did. And how do we do that? Well, a whole bunch of things had to line up. Sandy Bloom likes to say complex problems require complex solutions. So there's no kind of, silver bullet here, so to speak. There's a lot of things that happened. And again, I was super fortunate in my career to come to face this dilemma right at the time Sandy had published her book. The Adverse Childhood Experiences study had come out. In the mental health world, there was an increasingly active advocacy going on among people like that had formed that picket line that I described, insisting with the mantra, nothing about us without us. And nothing about us without us simply meant you should not be out there, you people, you hospital people, you leaders, you psychiatrists, you power brokers, you decision makers. You should not be out there constructing how you treat us without us there letting you know what it's like, what's helpful, and what our experience is. So we took that to heart very early in our efforts and our initiatives, and we got very transparent about what we were doing. And we included people who were actively on the unit at whatever moment in time, were welcome to come to our staff meetings and our visioning sessions and so forth, whether they came once or every day while they were there or whatever. They were welcome to be there, and having their voices throughout the journey was super important. But then, and here's a little bit of the mea culpa again, I feel like I'm being very defensive with you and saying, hey, I was a brand new leader. I really was new. I was so green and still had so much to learn about how to be a good leader. But I was, I was out there, I was reading all this science, I was rubbing elbows with the ACE authors and Sandy Bloom, and coming back to the unit full of ideas and saying, here's what we're going to do, here's what we're going to do, here's what we're going to do. And it wasn't very long before staff started kind of rising up and say, hey, what about us? What about our voice? What about our ideas? What about our safety? What about how we feel at work? And I'll let you into my brain just for a second, or my brain back then. My initial reaction, I never said this to them, but my initial reaction was, hey, you're getting paid a salary to come to work and do what I say and everything will be cool. But Sandy Bloom soon disabused me of that way of leading. And she said, no, Maggie, everybody needs a voice in this, or it's just not going to work. I was also reading at that time a lot about organizational development and organizational change. And I was reading the book by Jim Collins, Good to Great, about how to, change organizations, culture shift, and so forth. And that was really a big part of that book as well. Until you have everybody on board, and the way to get them on board is to actually deeply listen and then incorporate their ideas. I mean, these people on the unit that little old me was leading, they'd had decades of experience. And so I don't know who I thought I was, but anyway, I got the message pretty quickly, and really drew back a little bit on the initiative and said, okay, we're going to really completely focus on staff, what it's like to be staff here, what is frightening and toxic, what the stress levels are and where they come from, and how to get you all feeling safe. Because until you all feel safe, you're not going to be able to keep or help others that you're trying to serve feel safe. And frankly, you're not going to be very good healers if you're not feeling safe. So really drew back, focused on staff, and then things really took a turn for the better. I mentioned that I had started studying organizational development. I was also ingesting, felt like, boatloads of leadership books, learning about leadership, learning what that meant and how to be accountable. And I'll have a little story about that in a little bit. But at the end of the day, how do we do that? It was the creation of what would now be called a trauma-informed culture. We didn't call it that then, but it was culture change. And that's how we did that. So how do you create a culture? How do you change a culture? This hospital that we were in had been around in Salem for 125 years. We were just a flash in the pan. We were a small unit compared to the rest of the hospital. So how do you change a culture in that context? Well, we really relied heavily on what we'd now call trauma theory, and what we were learning from the Adverse Childhood Experiences study, what Sandy Bloom was teaching us, understanding what brains are doing when they're under stress, and what behavioral manifestations look like when someone's under stress. And almost always you can trace back what might look like anger or just obstinance or resistance, almost as always can be traced back to the person not feeling safe and not trusting what's going on around them. And that was just true so deeply and thoroughly on that psychiatric unit. So we started with trauma theory. We really used data a lot. We decided, okay, if it's true that what you measure is what you change, we're going to measure everything because we want everything to change. And so we came up with all sorts of things to measure, how many staff are on when there was a violent incident, what time of day it was, what had happened in the hours beforehand. We certainly measured seclusion and restraint, but that wasn't all. And that wasn't even center, frankly. That we did not focus on seclusion and restraint at all in the beginning. We just focused on all sorts of other things, the things that made people feel comfortable or uncomfortable. And we took the data, everything we were measuring, and we literally hung it on the walls. We would put these big graphs up on the walls of the unit where people were, where the people we were supporting and serving were, so they could see too. Oh, wow, Maggie, it looks like you guys had a really bad week last week. You had, 4 people break chairs or whatever. And we said, yep, we're really looking at what was going on last week because last week was a bad week. And so we just opened that. We got really transparent, measured everything, and then talked about it. Everything traced back to neurobiology theory. We really tried to understand what was going on in brains. I think, you all who are tackling this now, you're so much further ahead than we were, because back then it was just a brand new science. And we know so much more now. There's been and there are great pictures to look at and good models to look at. But back then we were still a little bit, making it up as we went, but it was still extremely foundational to what we were doing. One of the super fun things we did, because not only were we looking at neuroscience literature, but I was combing through anthropology and sociology literature, understanding when groups are violent and when they're not, and when individuals are get into arguments and so forth, and when they don't. I looked at the history of war even, and I know that we don't like to compare ourselves to war, but there were certain rules, maybe there still are, I don't know, but way back when there were certain rules about how to engage, rules of engagement, about how to keep things civil, if you can apply that to the idea of war. Anyway, one of the things we looked at a lot was the use of physical space, and went to the architectural literature. And there's a whole science about how to use space, what light does, what colors do, depending on what culture you might be in. So we had a great time. We had a pretty small inpatient unit, but we had a little work group made up of staff and any interested patients. And they spent a lot of time together saying, okay, how can we borrow ideas from Starbucks? Starbucks does amazing things with little tiny spaces. How can we make it feel like Starbucks in here? And so with a teeny tiny budget, I think we never spent more than $500 or $600 in a year on paint or a scarf to throw over a lamp or a beanbag chair thrown in the corner of the room. But we got rid of the big sort of historical, horseshoe of chairs in the common area where people were. And we broke it into literally what we saw at Starbucks, into these little areas where 2 people might sit together, or 1 person might sit comfortably with the table near them with writing materials near, or another table where 6 people could get together and chit chat. We got rid of the television because that certainly showed up in our data as a source of stress, where people seem to get into arguments a lot. And so we just had such a good time thinking of how to use physical space in a way that the space itself feels good to be in. And you all know this, right? You walk into a place, maybe it's a cathedral in England or the fairgrounds at your local county, and you're given so many clues and cues about what's kind of the norm and how you might feel there, whether you're going to feel serene and quiet, or whether you're going to feel like, anything goes and I throw my peanut shells on the ground or whatever. So we tried to get our physical space to speak to people who were just coming in, because often people coming into our unit were, strung out on meth or alcohol, or they might be psychotic with their schizophrenia, or so depressed they don't even know they're picking up cues from the environment. So we really worked hard to get the environment to speak to people who maybe verbally were not accessing information so well.
Maggie, I just wanted to jump in for a second. First of all, I love what you're saying here, and it really resonates with me, and I think a number of the folks in our audience as well. Very often thinking about some of the environments that we work around with schools and other settings, there's a tendency when behavior begins to emerge to put all the focus on the child and not focus on the environment, not focus on the adults present, but to solely put all of the emphasis on the individual that's exhibiting the behavior. And that's where we often see things like functional behavioral assessments and things like that. And I've long kind of advocated for this idea that in many of these cases we should be doing environmental assessments and trying to understand what in the environment might be getting in the individual's way or causing distress, especially when working with neurodivergent individuals that may have sensory, very sensory, affected. So, thinking about space is so important. And a number of people, as you were saying this, I'm just going to share a couple of comments here. We had kind of yes, changing the environment. That's the main thing I advise to do. If it does have to be expensive and the environment's impact countless variables. Nicole said, speaking of physical spaces in the classroom where K through 2 is, they just have seclusion closets in the classroom. And again, as you mentioned before, when you see someone else being restrained or secluded, imagine the anxiety and the trauma even that can cause people to have. And as Nicole mentions, wouldn't that be just a reminder to students of where they might end up if they don't comply? So the idea about environment is so important, but so often overlooked. I think it's easy to overlook environment and also the influence that the staff, caregivers, whoever they might be, have over situations in terms of their own approach or behavior. Of course, escalated staff member isn't going to help de-escalate a patient that is having a difficult time. So I love your focus there on environment.
Yeah, thanks. Breaking bread together, that next bullet point was, it's hard to know what gets a culture change initiative, what gets it to a tipping point, but breaking bread together, i.e. staff and the people we were serving eating together at all 3 meals was a huge game changer for us in terms of violent events. Our violent events just plummeted after that. And as one of my colleagues, Tim Murphy, likes to say, well, it's hard to throw a chair at somebody after you've just eaten soup with them. And so eating together, again, goes back to this very ancient rituals where people used eating together as a sign of willingness to be vulnerable with each other and to feel safe enough to kind of put down your weapons and eat together. And so that was a big shift for us as well. Guests among us refers to, we realized that there was a real power differential and sort of an attitude and maybe subconscious attitudes about the people we were serving, people who were coming in, as I said, maybe intoxicated, maybe psychotic. And we tried to get at that without, having staff feel like they were being criticized or blamed. So we got at it by saying, let's imagine, instead of expecting a new patient to be admitted, let's say that we have a new guest who's arriving, and that sort of shifts everything in your head, because you can't probably greet a guest who's just arriving differently than you greet, somebody who's being transferred from the ER for an admit. So, and that led to us starting to really fundamentally change our language, both in the way we talked about people, but also how we documented in our charts. And then finally, recognizing that, when you're trying to do a culture change, anybody who sets foot there is part of the culture. It doesn't matter if they're clinical or if they're the person who's sweeping up the floors or making the beds or bringing the food. Everybody is part of the culture. And unless you include everybody, it's going to be a lot more slow going. I'm going to only spend like 2 seconds on this slide. I just wanted to say that as we made progress, we took some of the practices that seemed to be working and turned those into policy. Trying to, was the guy Quint Studer, who wrote a book about how hardwiring for change or hardwiring excellence. I think that was the name of his books. We were trying to hardwire as we went, so that when I and other kind of philosophy leaders left, that things would stay in place. And so we knew that once we started making progress on some of these activities that seemed to be helpful, we tried to hardwire them by putting them into policy. Okay, but this is my fun slide, and I've already been bending your ear telling you story after story, but these are some of the ones that I think are sort of classic from my my experience. So we had a lot of bumps along the way as we were trying to get this initiative underway, with the initiative being, we named it the engagement model. So instead of, we didn't have trauma-informed language, so we said our goal is for staff and the people that they're trying to help on their journey can engage with each other in a positive way. So we called it the engagement model. And we had lots of bumps along the way as we headed for that. And because it's, we had 300 staff people, it's hard for 300 people to exactly know what it means on, well, how do you engage instead of doing what we used to do? And what did we used to do? And, what do we do now? So, it was definitely stutter step. But one of the things that happened one afternoon was when we had a man come in, and he'd had a pretty bad day. He'd been in a bar when police picked him up, and he'd been in some fist fights, and he was a little bit beaten up, but he was clearly, he had a lot of delusional thinking going on. And so his fighting at the bar had a lot to do with the thoughts he was having about other people who were trying to hurt him there at the bar. And he was intent on protecting his partner, his girlfriend, who was with him. And so in our new model, we had, when he came into the unit, he was brought in by police, but we had the girlfriend there too, understanding that she was a big part of how he was centering himself. And he almost immediately grabbed her in the room where we were going to get to know him a little bit better, pulled her onto his lap, and then threatened everybody, get out of here, let me out of here, or I'm not letting her go. So it kind of took her as hostage a little bit. I don't like that language, but that's how staff interpreted it. So the staff we had on that afternoon, they were very cool and very sophisticated about what we were trying to do. So they said, yeah, he's not hurting anybody. She's got her sitting on his lap. That's totally fine. We don't have to do anything about that. We can talk to him while he's doing that. So they just started, chatting with him, trying to get to know him a little bit while he was hanging on to her like that. We excused the police. We had them go because that was definitely riling him up. So, and, to cut to the chase, eventually everything was fine. It took about 2.5 hours, but eventually he allowed her to get up. He allowed her to leave. He agreed to stay, even though he was there involuntarily. He did really well with treatment, and eventually he came back as a volunteer. So it was all a very good story. But we had a couple of staff members who were super upset about the whole thing. They said, this is not right. This is not how we do things. You should not have let him hang on to her like that. You should not have let him control things for 2.5 hours. You're letting him be in control. And, I kept thinking in my head, but that's what we want. We want people to be in control because then they'll be safe. But obviously those staff members did not feel safe while he was in control. And it was just, it's such the epitome of what we're up against, So we had a happy ending to that story. It all went really well. In retrospect, maybe we would have done a couple things different, but really not too much. Never got dangerous. Actually, well, from my point of view, obviously from others, it did. The next one, police leave your weapons here. We were doing a run through, as Guy was suggesting. We were looking at our physical environment, and we would do little secret shopper where we'd come in and pretend we were coming into the unit as a person needing treatment, and look around and then just kind of narrate what we see. And one of our staff member was doing that little rehearsal or that little process, and he says, "Oh my gosh, look at that sign!" And the sign, there was a metal box hanging on the wall that had been there forever, and none of us had ever really even seen it, apparently. But he says, the sign says, "Police, leave your weapons here." And it was one of the very first things our patients would see when they came in. So anyway, we got rid of that. The singing nurses is a really interesting one. This man was we knew he was coming in. It was a planned thing from his provider in the community. He had schizophrenia, and when he was psychotic, he was really, really not in touch with kind of the here and now, and he was extremely wary and terrified. He'd been on the unit many, many times in the past, I think 8 times before. Every one of those 8 times he'd wound up in seclusion restraint. Several of the times he had his activities with staff had ended up in harming staff with a broken collarbone or broken rib. So we had not only our history with him needing seclusion restraint, we had our staff had history that kind of one of their own had been hurt by him. And of course, he himself had the experience that, when I go to this place, I wind up in seclusion and restraint. I mean, it's like the perfect storm, everything that, and so we had talked a lot about, okay, how can we make it different this time? How do you take something that's so wired into the whole dynamic with this guy, and how do we make it be different? Well, one of the aspects of him being there was that he would refuse treatment, and he was there under a court order, and we were to force medication if he refused it. And that's usually when the damage would start in the past when that happened. Once he was back on his medications, he always did well. He had a good response to medications where he, poor guy, he always inevitably wound up apologizing, which just hurts my heart. But anyway, so this time he came in, he was in his room, he was pacing as he does. And it was time for the nursing staff to take in this medication. So 3 nurses went in to his room, and there was the bed. He was on the other side of the bed, was in the center of the room. He was on the other side of the bed, and the nurses came in at the door. And they stood up, and I was watching on a monitor because I didn't know what they were going to do. They'd been talking about what can we do? What can we do different? What can we do different? They went in, they started talking to them, and they said, "Hey, we've got your medicine. We know you've been here before. We know that you've wound up in that awful little room tied down before. We're really going to work hard to make sure that doesn't happen this time." And it was like he wasn't listening. He was just pacing. At one point, he got into that sort of fighter stance with his legs spread apart and his hands out, sort of that, I'm ready, come on stance. They just kept talking in these low tones, these soothing low tones about acknowledging how scary it was to be here, acknowledging that he must feel in a great distress. And they pulled out the oral medications at this point and said, you do really well when you take this stuff. We've got water here for you once you take it. He was ignoring all of that. And all of a sudden, the 3 of them broke into song, and they started singing. And it turns out the 3 of them were in a local community choir. So they were singing in harmony, and they just kept singing. And, I was watching the monitor thinking, oh my gosh, this cannot be real. I am not seeing this. But they kept singing, and he stopped. After a while, he stopped his rocking. He relaxed his stance, and eventually he just held out his hand and he took the pills. And I don't know if he was just tired of listening to them or what was going on in his head. But anyway, that's the singing nurses. Let's see. Honey, when you bang your head, it makes my head hurt. We had community meeting, which is kind of standard on psych units, but we really changed it up according to Sandy Bloom's guidance. And instead of talking about like what the rules are or what the activities were, we talked about safety. We said, how can we get this place to feel safe? We would acknowledge unsafe things that had happened recently. Like we'd say, we know that somebody wound up going in the seclusion room. We know that affects everybody here. We just want to get back to feeling safe, both staff and you all that are here for treatment. How can we do that? Who has ideas? Well, another person had come into the unit the night before. Again, somebody we knew well. She'd been there before several times. And she'd also almost always wound up in seclusion and restraint because she was somebody who would beat her head on the wall, often until there was like blood. And so she'd be secluded and eventually restrained until that eased off. But we had agreed this time as staff that we were going to try everything we could to not let that happen. But she'd come in the night before, and we'd agreed that we'd have a lot higher threshold for her banging her head. We were going to, not intervene immediately in a forceful way. And instead we'd try talking and, lots of other stuff. Anyway, but she'd come in late the night before and had banged quite a lot throughout the night. And one of the other patients in the community circle that morning turned to her and said, honey, when you bang your head like that, it makes my head hurt. And the person's never banged again the whole rest of the admission. So hearing that from a colleague, from a peer, that's literally all it took. Go figure. The last one I'll do is the next one, and then I've got to stop because I promised I'd stop for questions and stuff. I could tell stories all day.
We're loving your stories, so feel free to continue. We're not going to kick you out of here by any means. So, the stories are great.
The last one I'll do officially anyway is, oh God, the next one's good too, though. I'm so glad. Okay, I might do two more. So this is to kind of guys, or that maybe it was the person in the chat who said, look at the environment. So again, we're in the middle of our initiative. We've been trying all sorts of stuff to keep, make it feel safe and welcoming and trusting and all of that. And this young woman had come into the unit, and she'd kind of gone straight to her room and just didn't come out. And I was super curious about, I figured, she's never been admitted before anywhere. It's her first time in a place like this. It must be pretty scary. And so I was trying to see through her eyes and feel through her feels. And so I was just kind of keeping track of her. And she'd gone in, staff had gone in to talk with her, taken her food trays, that kind of thing. She's been there about 36 hours. And then this one day she came out of her room and she was in the common area, was starting to strike up conversations a little bit with others. And so later on in the day, I sat with her and I said, if you don't mind me asking, obviously we're in the middle of this initiative to try to really create a safe environment so people can concentrate on healing. And I said, and I noticed you stayed in your room for the first couple days, and now today you came out. And it would help me a lot if I just understood what's the difference, and I thought maybe she'd tell me, the meds are kicking in, or I had a good talk with my doctor, or I'm just, more accustomed to it. I figured I'd get an answer like that. And she said, it was easy. When Jane and Janine came in this morning, two nurses, for shift. They gave each other a hug and one of them said, happy birthday. And I knew it was going to be a good day. And I said, tell me more. And she said, Jane and Janine hate each other. Don't you know that? And I said, no, tell me more. And she said, they're just always so crispy with each other. And I can really tell though. And she said, so it's just good to kind of stay out of their way when they're trying to work together because they don't really get along all that well. And she said, but today when I saw that happen, I just thought, they're really making an effort, and they actually hugged each other. So I thought it was going to be a good day and it was safe to come out. And I just thought, oh my gosh, people know so much about us and our private lives. And, if we're having a bad day or whatever. So anyway, that was informative for me.
Yeah, but Maggie, I was just going to interrupt real quick. The authenticity in the relationship is so important. We sometimes hear people in various environments kind of talking about like therapeutic relationships and the authentic relationship. I mean, when you're working with anyone that's experienced trauma or anyone that's having a difficult time, I think that those authentic connections, that real connection between people goes so far into helping people to feel safe. And it's just a beautiful story, but I mean, it makes so much sense. I mean, when we feel safe, we're able to, relate, and we're able to engage. I love that. I love that beautiful story.
Yeah, it was something. Okay, truly the last one I'm going to do, at least unprompted, is I'm so glad you did that. So, so bringing all these staff along in this big culture change was quite something, and I've probably underplayed that, but it was quite something, and it didn't happen all at once. I mean, 300 people didn't suddenly say, "Hey, Maggie's got a good idea, let's go do that." It was not like that. And some people even wound up leaving. Others came, fortunately, but it was little by little. And a couple of the toughest folks to gain their trust and assurance and confidence were our doctors. And one doctor in particular, he just was so skeptical about the whole initiative. But he hung in there with us. And then this happened this one day. And so a young man had been admitted to the unit, and I was on the unit also because he had come from the ER with, quite the story of being pretty energetic. He and probably overactive. He turned over a bunch of trays in the ER and, damaged some machinery and so forth. So he was pretty wound up, let's put it that way. A young guy, maybe 20 years old, super strong. So he had come in, and again, in the old days, he's somebody we probably, and I'm embarrassed to admit this, but remember it was the late 1990s, so I get a buy, okay? But in the old days, probably he's somebody we would have put directly into seclusion until we could figure out how we were going to manage things. But this was not the old days, this was the new days, and so brought him in. And we were trying to figure out how we could not make him feel more geared up by a lot of us, surrounding him or watching him or whatever. So we're trying to give him lots of space, letting him roam the unit so he could get a feel for it, figure out what it was all about. He'd never been there before. He was unfamiliar with it. He was pretty, from a psychiatry standpoint, he was quite manic. So he was physically very geared up, as well as mentally. You could tell that his mind was just really, really going 100 miles an hour. So he was having a really hard time processing any information from us. And he was having a hard time giving us information. So we were just trying to give space and all of that. But he wanted to use the phone. And this was pre-cell phone days. And he wanted to use the phone. And so, we got a phone out for him. He used it, was unable to dial. He was unable to tell us what the number was. So he'd get frustrated and he'd throw the phone down. And, I could tell staff were getting a little bit nervous about giving him the phone over and over because it seemed like it could be a projectile at some point. So after, I don't know, fifth or sixth time, and I just saw it happening. This one nurse, very experienced nurse, great nurse, she said to him, she says, what, the next time he demanded the phone, 3 seconds after just having had it, she said, let's figure out something else to do for a little bit and then circle back to this. Well, that enraged him. left over from the old days was this plexiglass shield around one of the areas of the nurses station. We'd taken down almost all the barriers to that as part of our physical remake, but there was this one kind of stray leftover plexiglass shield that went almost from floor to ceiling at one end of the nurses area. And when she told him no about the phone, he just took his fist, he drew back, and he went right through the plexiglass. And it was pretty spectacular because it was like, it was like 12 feet tall and it was only about 4 feet wide, but it was big. And the whole thing just went, exploded into a zillion pieces. And for a split second, I don't think any of us knew what we were going to do. But this one doctor, he goes rushing up to this guy and he puts one hand on his shoulder, the other hand on his kind of elbow. And he says, "Oh my gosh, I'm so glad you did that. I've been wanting to get rid of that forever. Are you okay? Let's go out here. Let's make sure you didn't get cut or anything. Are you okay? I'm so glad you did that." And it was so counterintuitive for any of us. And the rest of us just stood around and stared at each other going, "Oh my gosh, I guess he's on board." Anyway, so those are some of my stories. I'm going to stop because I'm losing my voice, but I'm happy to take questions or let Guy fill in anything that he thinks I left out.
Well, I mean, the hard part is that I have teasers to your next stories about a doctor being poorly dressed and why you locked up the checkers. And I don't want to push your voice, but if you want to share another story or two, we'd love to hear them because there's a lot of parallels here in different settings. I mean, a lot of the parallels of why do kids today gosh, I mean, you started this work. When did you start your work in reducing restraint and seclusion?
It was 1998.
1998. So well over, almost 25 years ago, we're making tremendous progress of reducing and eliminate these practices in our, in acute psychiatric settings. And I think I probably shared this with you before, like it almost blows my mind that, that we're still doing these kinds of things in our educational settings. To know how often, generally kids with disabilities, more often than not, it's Black and brown kids, very young kids, 5, 6, 7, 8 years old, that are being restrained and secluded in schools, many of whom have trauma history. And it shocks me that these things are still happening. But, these stories are very relatable in a way that, it's very often this mindset of compliance and control, right? You can't let people control things. You shared that first story about, well, why did you let them control the situation? We find that, we're getting, I think, more leadership on board with some of the approaches. But then there's a lot of questions from staff like, well, this child came to your office and, ended up leaving with a sticker and, a smile and, well, he needs consequences, right? So there's a lot of parallels. So, if you feel that you can share another story or two, I'd love to hear them because even just looking at the last one, why do you lock up the checkers? I'm thinking about a comment that one of our educators had made earlier, and I have to find it now, but was talking about how she was told to lock up the books, when she was setting up her classroom, not put the books out because the kids are going to destroy it. And, so anyway, these other stories are calling to me. If you have the energy to go through another one or two, we'd love to hear them.
Thank you. You're so kind. Yeah, I love telling, obvious. I think it's probably obvious. I love kind of reminiscing about all of this. So the next one is she denies it was and sorry, behind me I'm getting an echo too.
Let me mute my audio. Maybe there's a
great. That's better. Thank you. And if you're hearing any snorting behind me, it's my dog who's suddenly woken up and she thinks it's 5 o'clock somewhere, which is dinner, which is not accurate. She must be on East Coast time. Anyway, So she denies this was a suicide attempt is one part of this. And then the doctor was fully oriented but poorly dressed, and he had inadequate eye contact. This all relates to how we use language in our written documentation about people that winds up causing us to think a particular way about people. And so this story is my aha moment was when a man came in to the office, my office, asking to correct his wife's medical record. That's what he came in to do. And she was with him, but she never spoke during the whole thing, which was sort of heartbreaking to me because I felt like we'd lost an opportunity to build trust with someone we might have been able to help later on down the line. But anyway, he had a hard copy, a printed out copy of what's called the History and Physical. In medicine, a history and physical is sort of the whole story of how somebody comes in and why they come in, and a description of the circumstances and their symptoms and that kind of thing. So he had this printed out 3 or 4 page document. And at the beginning, the typical thing to put at the beginning of a history and physical is identifying information. And so he handed it to me to read, and I started reading identifying information. And it says the patient is a 36-year-old white married female. And even that part, as I was reading it out loud, he asked me to read it out loud, I thought, oh, that's so dehumanizing. The patient is a 36-year-old white married female. I mean, it didn't. Anyway, but that was just a thought I had to myself. But then it says she was admitted to the intensive care unit after a Tylenol overdose. She denies this was a suicide attempt. Well, I bet many of you can guess which word was circled in thick red pencil. It was denies. And so I paused, and he said it was not a suicide attempt. She inadvertently overtreated a headache she just couldn't get rid of with Tylenol, and she wound up taking too much. And I said, well, yeah, I mean, it kind of says that, she says it wasn't a suicide attempt. He said, no, it doesn't say she says it wasn't a suicide attempt. It says she denies it. You don't believe her. And I said, oh, I see what you mean. Got it? Okay. And then the report goes on, history of present situation, and it goes on to say, the woman has came in with an overdose of Tylenol into the intensive care unit. She's found to be quite depressed and is transferred to psychiatry for evaluation. She's been depressed since the birth of her first child, and has seen multiple psychiatric providers in the community, but has been non-compliant with treatment. So I bet you know which word was circled. It was non-compliant. We love that word in medicine, non-compliant. And he says, it's not that she's been non-compliant. It's that you all have been non-compliant. She's breastfeeding. We want to have another baby. We don't. She doesn't want to be on medications. And that's all she's been offered is medication, medication, medication. So we keep going to different providers looking for somebody who will work with us, and they won't. And you call her non-compliant because she doesn't want to be on medicine because she's breastfeeding and wants to be pregnant. And I said, point well taken. And then the report goes on and on and on. And I'm so embarrassed. So there are so many red circles. There's, she alleges she only drinks 1 glass of wine on rare occasions. Alleges. Where in the heck in medicine do we get off using a word like alleges? On and on and on. And as I read it, I realized, we've lost this woman's trust forever because she believes that we don't believe her. And maybe we don't believe her because sure, the way we've written this report sure makes us sound like we're skeptical and suspicious of absolutely everything she says. And so that led us to start digging into the language that we use, both in our own minds as well as in charts, because it's not just us that reads those charts, other providers do too. And so when we write our little notes and say he was belligerent or something like that, somebody else is going to read that and not like him very much. So we started, reading through the lens of do no harm. And then somebody got the idea, let's read everything we put in somebody's chart, let's read it with the person we're writing about, nothing about us without us. And that changed our language in a big fat hurry, let me tell you. We started writing in a way more positive, optimistic, or neutral at best, at worst way. And then somebody said, one of our patients suggested, how about we do an experiment and we keep notes on you? And so we did that for a couple of weeks, and it was kind of fun because, first of all, we felt like what it was like to be documented by people. And this was an excerpt from one of the documents that, because in psychiatry, we love to say the person is oriented or not, because it helps us know how much in reality. So this person had written, the doctor was fully oriented, but poorly dressed. And he had inadequate eye contact, which was really true about that doctor that day. So what can I say? Okay, the last one, Guy.
Yeah, and just interject here. I mean, the point being made there, words matter. Words are important. Words are, I mean, we take these words to mean things, and when people are using words, I can't tell you, and maybe those that are watching can, but how painful it can be for a parent who is sitting in an IEP meeting, a team of people there dedicated to helping a child, and hearing all of the negative words that are used in relation to that child. The words we use really matter. And, for instance, we often see kids being restrained and secluded in schools, and you hear about violent children. And, what I most often see when I see a kid that's being restrained and secluded is a kid that's not having their needs appropriately met. The word violence assumes intent. And I think that, many of the kids that are getting restrained and secluded are not kids that have a violent intent. Rather, they're frustrated. Their needs aren't being met. They've been through trauma. So the lenses we use are so critical. So I love that story for kind of bringing that up. I'll be quiet. And if you can get through the one last story there, I appreciate you being willing to go through with the voice probably being ready to quit out on you there.
Well, you guys are probably tired of listening to it as well. But so I told you about community meeting and how a couple times a day we'd bring everybody who was interested together, staff, other people on the unit, cooks, environmental crews, as well as the people that were there for treatment. And we would sit around and talk about how to get the unit feeling safe. And if it is feeling safe, and if it's not, how are we going to get it there? We did that twice a day, every day. And we'd had a new person join us, a young man. I think he was probably 18 or 19. I think from his history, it was the first time he'd really experienced what was I don't remember if it was a episode of being manic or maybe schizophrenia and psychotic, one of those things. Anyway, he was kind of lost in his own head. And he hadn't really spoken to anybody. He was kind of mumbling to himself. And none of us had really connected with him yet. He'd only been on the unit maybe a day. And so the rest of us were sitting in a circle having our discussion about safety, and he was walking around the outside of the circle. And almost, I remember having the feeling it was like playing Duck, Duck, Goose or something, because he just would walk around and around and around. Every time he passed behind me, I wondered if he would like tap me on the shoulder and I'd get up and start walking too. But anyway, we were all pretty aware of him doing that, but we're allowing it and just kind of curious. And so we were all talking about what felt safe, what didn't. Somebody had brought up, hey, would really like to have access to, I don't know, like water machine or something. I don't know. It was something easy. And we were saying, well, yeah, we don't know why you can't have access to that. That's ridiculous. Yeah, we'll make that happen. And all of a sudden, this guy who had not said anything that was that we could understand, anything intelligible, the whole time he'd been there, suddenly stopped his walking and said in very crystal clear, perfectly clear voice, he said, "Why do you lock up your checker game?" And we all just were kind of stunned and said, "We do." And he points at the cabinet, the game cabinet, and sure enough, it's locked. And sure enough, you can see the checkers through the glass, but the checkers are locked up. And so it was such a, and then he went back to walking, but it was such a cogent question about, wait a minute, if we're talking about safety, why do we lock up the checkers? And what is the meta message behind locking up checkers? I mean, if anything, that gives the clear message that, wow, this is a dangerous place. You can't even play checkers, you know? So anyway, it's, you know, we learned so much from the people that we're trying to improve the situation for. We learned so much when we really started deeply listening. All right, I'm done with my stories for now, but I'm happy to answer any last questions. And Guy, I know that we're almost out of time too.
Oh yeah, we're fine as long as you're not going to run off the screen. We will see if anybody has any questions that is watching. We can probably take a couple of questions, and I'm gonna just while I pause and wait to see if anybody has any questions. I'm gonna ask you a question or two just to kind of bring us back around. You know, your work in this started in the '90s. You know, kind of after your own you know, personal revelations and thought that you know, that things could be done better. And I really appreciate the stories. I'm going to remove your screen since we're done with that, but I will point out that the contact information is there. So just make note of that if you're interested. We've got the email address there, and I can always provide that to folks as well. So let me go ahead and remove that. But let me just kind of circle back at a high level. You know, when as you reflect on this work that you were involved with to not only change the culture of the way that the people you were working with experienced what, you know, the interactions with you in the facility, you know, reducing and eliminating things like restraint and seclusion, but so much more broader than that. It was about changing the environment, changing the perspectives of the people that were working, you know, in those facilities. You know, what do you think were the greatest challenges to that work in terms of changing culture and getting people to move in that almost a service oriented direction, right? So it's almost how do we view you know, the patients that are in here as, you know, not as you know, and the way you explained it, I thought was fantastic. But very often, you know, kids in schools and you know, patients in you know, mental health settings are seen more akin to being inmates. And I would even contend that we should be, you know, working far differently with people that are in prison, but it's often a very compliance and controlled atmosphere. So, what to you were some of the greatest challenges in trying to bring about this culture change?
You know, I think I got in my own way an awful lot. I would say that one of the statements I'd make is that the leadership for this sort of thing, this sort of culture shift, it takes a lot. And I don't hold myself up as a shining example because I really learned as I went. But in retrospect, I made a lot of mistakes. Definitely made a lot of mistakes. I was really fortunate to have a mentor and guide in Sandy Bloom, and then others. I had a partner, administrative partner, Tim Murphy, who was in it with me. We had a few key staff people who were true believers from the very beginning. So I was fortunate, but I think the leadership and the stick-to-itness, I mean, this is not something that happens overnight. You don't get rewards very quickly. Comes pretty slowly. So I think that's overall for any kind of culture shift. That's a big one.
I love that, and I agree with you. And it's hard. It's hard work. The people that are out there sometimes trying to bring about that change, it sometimes isn't welcomed. And you know, certainly I know people that have had that experience in education where they're out trying to make a positive difference, and people are like, "Well, why are you doing that? This is not how we do things here."
Yeah.
So it's difficult. I have a couple of comments and questions here, and I'm just going to try to get a couple of them real quickly. Ellie, who is fantastic and a friend over in the United Kingdom, said, "Amazing to hear this. Thank you." The meta messages. Is this something that sits within all of society or more so within your space? Really interesting phrase. Is it linked to the power and control dynamic?
um, So if you're asking kind of what I mean by meta messages or where it comes from, it's probably mostly from my psychiatry background, sort of hearing the message within the message, or maybe the message that's a roll up of all of the different components of things that I've heard. So it's sort of a shorthand way, it's sort of a paraphrasing of everything that I've heard and is going on and is being said without being said, if that makes any sense.
Okay. We have a comment here from Karen, who's an educator, and says, I'm curious how you address the pushback you received around the de-escalation techniques. I recognize that you had a position of authority, which is different from my own situation, but looking for language and guidance with how you've dealt with any resistance. And as a little bit of background, I think part of where Karen's heading, just from some previous conversations, is, a lot of the training out there around de-escalation, around crisis management, a lot of that training is actually the training that provides restraint training. So there's a bit of a this ideology that you need this training, which in fact could be perceived as encouraging people to use physical restraints.
Yeah, it's a super good question, and it's a complicated answer because I think you have to go back and back and back. And so what we very purposefully didn't take on events as standalone events. And so for instance, if there was somebody who was actively, engaged in being upset or whatever, we stood back, or the leadership stood back and said, nursing staff, other staff, you do what you need to do. And sometimes that ended up with them using seclusion restraint in the early days, and sometimes it didn't, depending on which staff were involved and so forth. But then what we did was we took it on and we used tools from, I don't know if any of you ever heard of crew resource management, CRM. It comes from the airline industry. And it arose after a few plane crashes where, in retrospect, several staff members had tried to tell the pilot that they were about to crash, and the pilot wouldn't listen. So they implemented this crew resource management where anybody on crew in an airplane can raise an alarm, and everybody has to listen and get together and respond to no matter who it is. So we borrowed from that. And then we also used the root cause analysis from investigating what are called sentinel events in medicine. And root cause analysis, there are a few different techniques, but one of them is the 5 whys. Why did that happen? So let's take my guy that broke the window. Why did he break the window? Well, he was upset because he couldn't get the telephone. Why couldn't he get the telephone? Well, because he'd gotten it 5 times before and he couldn't use it. Why did he get it 5 times before and he couldn't use it? Well, because, you keep asking why, you keep going back and back and back. So we combined crew resource management with the 5 whys, and then we would debrief incidents and we would learn so much. And one of the main things we learned early on was that somebody on the unit predicted the person was going to have a hard time, sometimes as far as 12 hours later, but always within about 5 hours. So as long ago as 5 hours ago, somebody on the unit, somebody on staff predicted what was going to happen. But because of their positionality or whatever, they hadn't historically spoken up, or they didn't in that. So we tried to create an environment where anybody, crew resource management, where anybody could say, I'm just noticing a lot of, angst there. That guy just hung up a phone. Sounds like maybe he's getting his kids taken away from him, not really understanding it. I wonder if we can do something different now instead of waiting for the whole thing to blow up 5 hours later. So we didn't focus on the de-escalation in the moment very much or very often. So Karen, I don't know if that helps you very much. But we really took a much broader view and backed way up.
That's great. So 2 other quick things here. Spectrum Life said, what advice do you have for disabled people, self-advocates, advocates in regard to steps that they can take to make change in our local hospitals and healthcare institutions? And of course, as you probably, well known, often it's individuals with disabilities that are more apt to be, restrained, secluded, medicated, yeah. So any thoughts on that?
Well, I suspect I could learn more from you than you can from me. I've just recently been asked to work with the state of Hawaii around how they can change their system, their disability system for people who experience they have a really prescient leader there, a woman named Mary Brogan, who's wants to do exactly what you're describing, but it's not an area I've spent a lot of work in. But I would say for anybody, you included, who wants to do that advocacy, there's a ton written now. And I'm pretty left brain, and so I rely on articles in science and that kind of thing. But I would take that to the leaders of the hospital. How things really started getting change in this country happened with the Hartford Courant, the newspaper, that raised all of the deaths that were happening as a result of seclusion and restraint. So, you gotta kind of rattle the pan, beat the pans, and say, hey, there's a better way to do this, and we're living in the dark ages, administration. So I don't know that helps you a whole lot, but you've got to catch the attention of that matters to them, whether it's financial bottom line or their reputation or the fact that they're practicing medicine in a way that is 2 centuries old. That's my best thought right now.
Great. And I got another comment here from Ellie, and Ellie's fantastic. We actually have interviewed Ellie before. Does a great, she did a great TED talk about flipping the narrative and the importance of language and words. But Ellie just said, I get on my own way a lot. Powerful to say that. Wish more would be so humble. Much to learn from you, and thank you for the answer. Much appreciated. And on that note, Maggie, I want to thank you for spending more time with us today, and really appreciate your experience and your stories. I'm a big believer in stories, and I think that stories can really connect with people and ultimately influence a lot of change. And I know that the work that you have been doing through your career, has been really meaningful and influential to bringing about positive change. Certainly excited to have you as an ally in some of the work that we're still trying to do. Again, I think we've got a lot of places that we can make more progress, but it takes people like the people that are generally watching our program here to, begin to influence change. And thank you so much for spending time with us today. Any final words or anything final you want to share with our audience here today?
It feels like such a luxury in my busy working life and so forth to just stop and have people listen to my stories. And it just reminds me that listening to each other is so powerful. And that's certainly true for me too. So I feel like you all have given me quite a gift today. It's definitely the high point of my week. And I just really appreciate it, Guy. I'm so glad I got to know you.
I appreciate it, and to me, it's the other way around. The gift of you sharing your experience, and I'll just say to you, and anytime you need that kind of break, we'd be happy to talk to you. But I really do value your time and the contributions you're making, and I've got some ideas in Oregon that have been floating around in my head recently, so I might reach out to you regarding some of that as well. If you want to hold on for 1 second, I'm just going to make one final announcement, and then we will end the broadcast. And I just want to thank you one more time. So just let me share here real quickly what we've got coming up next week. So we're a little off our schedule here in that this one was scheduled for last week, and I appreciate, Maggie, your willingness to move that around to fit my schedule that had kind of gone a little bit sideways. So next Thursday, we have another live event. We've got Sandy Lehrman joining us, and Sandy will be talking about the 5 behavioral roots, the importance of digging down to identify the underlying reason, and then responding with compassion to make things better. So again, very much honed in on, kind of a lot of our theme here, which is moving from, approaches that are based in compliance and control into how do we better understand and support people. So I want to thank everybody that joined us. Looked like we had a good group of people here. And yes, Ellie, this is being recorded. It will be on our YouTube page as well as on Facebook. And we encourage everyone, as always, share these. We want you to share them with other parents, other professionals, people in other, industries as well. I love what Maggie was sharing about kind of all the places you learn things, whether it was the airline industry or hospitality. And some of the most influential work that I've ever seen has taken that approach as well. We have a woman that presented to us before. She's going to present at our event, but she wrote a book called Talk to Me, and it was about what educators could learn from hostage negotiators. Wow. So people that are professionally, working on things like that. So a lot of great opportunities. So thank you, everybody, for joining us today. Thank you, Maggie, for being here, and we will see everybody else back here next week.